All right, everybody. Hi, welcome to the 104th neonatal and education online education from the KIMS Cuddles. And I'm Juhita. I'm pediatric physiotherapist and certified neonatal therapist. So today we are going to look into the overview of neuromotor and neurobehavioral assessments in NICU and beyond. So let's start with looking into the what kind of assessments we use in the NICU. So the first and foremost thing will be your clinical observation, what you see, and then you observe and come up with some other plan, what you want to go for further. So that will be the first. Then second will be there will be some standardized assessment where you can score something, you can interpret the result, and then you can correlate it with the baby's development, how it will be the right now. These are the scores, how the baby will be once the baby will grow. That kind of some interpretation will be there through the standardized assessment. In that, you can also tell that when you want to send the child for any kind of interventions. Then is the history taking. Why I've included history taking as an assessment? Because when you know about the history of a child, you come to know so many things that what all thing the child went through and what all issues he may face in the further development. So that's why it's very important. So today I'm not going to talk about the clinical observations or the history taking part. I'll just talk about some standardized assessment which I have come across through this many years working in the NICU, so that some are some gold standardized assessment and some are like easy to apply in the NICU and beyond. So before starting to that, I want to tell that the best time to perform some assessment is when the child is in a state 4 or 5. I will elaborate that what do you mean by the state of the child in the further slides. And more things like the high risk preterm infant, they have lower flexion tone in their limbs and more hyper excitability, and less smooth and fluid-like movement as compared to the term babies. So what I can expect that the fluid-like movement means like some movement starts from the hands and then it goes like a some wavy kind of movement and it ends to the other side or from the body. So this smooth movement will you will see observe more in the term baby, but not in the preterm baby. So that is something which we should be aware when you start your assessments. It's not going. Not going. Sorry for some technical glitch. So, okay. So now what we are assessing. Be quiet. Okay, so what we are going to assess first, we assess about the neurobehavior, which includes some self-regulation or attention and consolability and the alertness. So basically, in neurobehavior, you will be observing the pattern of the child. Are the child able to give the focus or attention when you are there, or the child is consolable, or the child is able to self-regulate all these things you will be observing is a part of the neurobehavior. Then there will be a cranial nervous examination. So we all know we have 12 cranial nerve, and then there are certain ways to examine all the cranial nerves. Then there will be neuromuscular examination, then some primitive reflexes, and some auditory and visual examination. So today I'm not going to cover the cranial nerve examination and the primitive reflexes. nor the audio or visual examination, something separately I'm not going to tell, but definitely the neurobehavior and some kind of neuromotor assessments, standardized assessment has the component of auditory and visual exams as well. In fact, some examination also has the primitive reflexes examination. So that I will be telling what all things are there. So let's start with the basic assessment, which we all know, the ABGAR score, which was developed by Dr. Virginia ABGAR in 1952. And the new Ballard maturation assessment, which was developed by Dr. Jenny Ballard. Okay. So this ABGAR score will tell you more about the state of the child when the child is born. At that time, what child is able to do. And it will give you, it's very important, it will give you a whole picture of the child breathing pattern, then the movement, and is the child active or not. So all those things, if the child cried or not, so that will be included in the ABGAR score. New Ballard maturation will tell about the how much the maturity the child has reached. So what is the gestation age the child is born? Is the maturity level is matching to that gestation age or not? That you will come to know from the new Ballard maturation assessment. We will look into that, but I'll not go very much detailed. It's usually done by the neonatologist when the child is born, and the new blood is done within the first week of the birth. So it's very important to do these two assessments. Then comes the test of infant motor performance. It is kind of developmental assessment. Okay, so which is developed in 1993, and later it's revised by Suzanne Campbell and the colleagues. So in this, you will come to know the motor performance. What you are giving some inputs and how the child is able to perform motor. That you will come to know from the test of infant motor performance, that is called TIMT, and Alberta infant motor scale, that is also purely on the motor performance. Okay, the Alberta infant motor scale is developed by Martha Piper and Jonah from the University of Alberta, Canada, between 1990 to 1992. Okay. Now, next comes the Hamilton neurological assessment at term. So, which was developed in 2002 and it was updated in 2002. It's very important to know the Hamilton angles. I'll talk a little bit about that as well. But it has from birth till 6 years of age. So, from my limited knowledge, I have come across only this one assessment, which gives you a picture from birth till 6 years of age. And the scoring is also depend upon the age, that a particular age you can open check the child is able to do that or not, and then you can score, and then you can put in the intervention. Okay, then comes the general movement assessment. So that was developed by Practo and the colleagues in 1980s. Then comes the Premi Neuro, that was developed by Donna and Patricia. I don't remember the when it developed. Let me see. I'll come back to it, you with that. Then comes the Hammersmith neonatal neurological examination and Hammersmith infant neurological examination, which was developed by Lily Debovitz and Victor Debovitz. Okay, so this examination is very easy to perform, and it also gives you like from birth till the 2 years of age, all the performance you can check and how is the child is developing. So some part is like the neonatal neurological examination will be from 0 to birth to 2 months of age, and the infant one will be from 2 months, or let's say 3 months. Sometimes some people use from the from 3 months of the age, then till 2 years of age you can perform it. Okay. So next is the ENVO, which is purely on the behavior. So newborn behavior observation, which is published in 2007. and it is a shorter clinical variation of NBAS, which is Newborn Behavior Assessment Scale, which is developed by Dr. T. Barry Brazelton. So NBO is easy to perform and it's not that much time taking. So that's why I will also show you how the scoring sheets are there. It's very easy, and it's online also. You can get the training and all. Then also there is some assessment from Brazelton, that is state assessment. Basically, it's not an assessment. It's like you come to know that what is the state of the child, which state the child it is right now. Like child is sleepy, drowsy, alert, or active alert, or crying. All this state, it has a proper description, which you can read, and you detailedly you can understand the which state the child is right now. Then comes the NOMAS, Neonatal Neuromotor Assessment Scale, which is developed by Marjorie in 1983. So this is also very nice assessment to understand the sucking pattern and suck swallow breathe coordination of the child. So I will little bit give the glimpse of all these assessments, so that in your unit what you want to use and how you want to get certified and everything, you'll get information about that. So Abgar scale, it doesn't need any kind of certification, and you have to check it immediately after birth and test it at 1 minute and 5 minutes. Then at the 10 minutes, if the Abgar score still remain less, then you do again do the Abgar score at the 10 minutes. So the score is from 10 to 0, and the 7 and above is considered as a good score. Okay, so let's see into this. So it has the component like skin color, pulse rate, reflex, and grimaces, muscle tone, and respiratory effort. So the 0 says the child is not performing well, and the 2 says the child is performing well. Okay, and the acronym is also developed accordingly. So here you can see the score 3 and below are generally regarded as critically low. 4 to 6 is fairly low, and 7 and 10 generally normal. Okay, so this is something which we should be remembering when we do the Abgar score. New Ballard maturation scale. So this is a tool to access the gestation age, as I said already. Then it evaluates the physical and neurological sign of the maturity in the newborn, and it must perform in the first week of the life. The scale ranges from 0 to 50. The higher score indicates more mature baby. So let's see. So these are some components of the Neo-Ballard score, where you see the posture of the child, and square window means like you just check the wrist angle between the wrist and this forearm. So you'll come to know how much is the angle between that. Then the arm recoil while you are doing this folding and then leaving it, and how much the child is able to recoil it. That will come under as a arm recoil. Popliteal angle, you'll try to put the heel towards the uh, ear, and then you will that is also one more another component. So the manure is little different, but it's almost similar. Okay, so in this picture you can appreciate how they have nicely given the diagram that how to perform these all the components. Okay, then you will see the scarf sign, where you will see that how much the elbow is the elbow crossing the midline or is in the midline, or it's not crossing the midline. It will tell about the muscles tone in around the shoulder and all. So those are things also included as a neuromuscular maturity. Then, so these are some physical maturity components are there, where you will see about the lanugo, means the small hair on the body of the surface of the baby. Then plantar surface, you will be observing for any creases are there or not. Then the breast bud and all you will be observing. Then ear and the eyes you will be observing, are they properly thick? The stiffness of the cartilage is there or not. Then genitals you will be observing, male and female, that is already given what you should be observing at that time. And the maturity scale, as you can see here in the left hand side, that the score is from starting from the 20 weeks till 44 weeks. So you have to check the score accordingly. So weeks are also given separately, and where the child is falling, that you can see. If the child is, for example, 36 weeks, the child is born and the score is 25, then you should give the score, the child gestation age as a 34, sorry, not a gestation age, the maturity age as a 34 weeks. And if the child is gaining the score of 30, then definitely you will be telling that the child is age appropriately matured. Okay. So this is the way you can learn about the Ballard score. Then test of infant motor performance. Okay, so it can be used from 34 weeks till around 4 months of the age. It has 42 items to assess, where it is includes some posture movement and postural control, basically in sitting, supine, and the sideline, and in supported standing. So 30, basically you are checking the performance of the child motor movement. Okay. Then it has the 30 item, which is spontaneous movement. Like it's you don't have to score it. It's just yes or no. Okay. So I will show you the. So this is the scoring sheet. It comes like this. Full sheet is there, where there are some observational item. So here are some observational item where you can tell that yes or no is the child is able to perform or not, or some kind of movement is observed or not, like reciprocal kicking, fidgety movement, ballistic movement, all those things you will be observing in the child. Then there are some performance, like 29 items are there which you are gonna perform. Okay. And it is helpful to find out the delays prior to the 5 months of the corrected age. It's very nice, uh, though it is time taking, but the assessment is very nice. It's very detailed, and you get very nice good picture that the child is how is the child performing, motor performance are there. Plus they have some cutoffs where you can understand the child do really needs the intervention immediately, or you can wait, or child doesn't need the intervention. So their cutoff value is a little lower than the other assessments. So sometimes there is a controversy that they are like over-diagnosing, and maybe we are saying the child is no, the child can perform well, but still people are putting in the intervention. So this kind of controversies might you may hear sometime, but the thing is it's very nice and safe to do, and of course you can get a very nice clear picture about the motor performance of the child. So I have just kept the picture of TIMT, how it looked, the front page and all. So, and they also have the TIMSI. So TIMSI is nothing but a screening test. It is a shorter version of the TIM. And the way how you score, that is also a little bit different, because TIM take around 40 to 40 minutes like that to perform, but TIMC takes a little lesser time because it's just an scoring tool. So basically you can just use a scoring tool for initial age, and it's like up to you according to the caseload of your hospital. You can take a call and get the certification done. Both the certifications are available now. It is also happening in person. Previously, it was available. I think it's still available online. You can take the subscription and you can learn about them. Next is the Alberta Infant Motor Scale. So Alberta Infant Motor Scale contains 58 items grouped under 4 positions, which is prone, supine, sitting, and standing. So little bit you will see some similarity. Okay. But the items, number of items are different. Okay. This which describe the development of spontaneous movement and of the motor skill of the child. Okay. And it can be used for preterm and full term from age 40 weeks to 18 months or pre-walking infant. So that means if the child starts walking, you should not be using this anymore like that. So see, this has little bit longer accessibility. So basically, you can do this Alberta Infant Motor Scale till 18 months. So why I bought both the scale here to show you, so that if you are going for some research worker, you can take a call that which motor scale you want to use. Okay, and then you have to observe all the aspects after performing, and then you will do the total of it. At the end of the evaluation, the total score is summed and converted into the percentile in a chart available in a score sheet, okay, which identifies the percentile of the overall motor performance of the child, which may range from 5% to 90%. So let's break it up. So how it ranges and what it be like, what you can tell about the percentage. So if the percentage come from 0 to 10, it considered as a atypical development. If it comes from 11 to 25, suspected performance. From 26 to 75, it's a normal performance. 76 to 90, it's very good. And from 91 to 100 percentile, it's an excellent performance. So you see here this graph. In this, you can jot down whenever the child is coming for your follow-up, and then you can see how the child is performing. There is any improvement or not, like that you will understand. So it's very nice visual pictures are given in this whole, like the way in the tempt it is given, like that same way the Alberta Infant Motor Scales also has all the pictures given over there, how you can assess and what you should be observing. It's detailed written what you should be observing in that. Okay, and then how to score it. So next come the ML Tyson. So it's a single tool for the neurological examination from 32 weeks post-conception till 6 years, or around the, mostly like it's good to perform around 40 weeks of conception. It is based on a fixed set of observation and manure, and the result must be scored according to the child's age. It has designed a charts. They have some charts on which examiners can record the result of each observation and manure. Each chart has 3 sections: describe passive tone, motor activity, reflex, and postural reaction. Okay. Then the examiner circle the score of 0, 1, or 2 according to the information given in the technical description. Though it has a very big manure, uh, it looks like, but it is very easy to perform, and it doesn't take much time. So I just want to highlight this 2 paper, which explains very nicely about the TIMT. So, Emil Tyson's neurological assessment. Okay, so if you have time, you read about these two in this 2 paper. They will tell you how to perform all the manure, and what precaution you should be taking, and how you will be interpreting the result. That everything is discussed very nicely. Though it is little older paper, but they have written very nicely about the scale. So this is how the scale looks like. Here you can see some passive muscle tone, which where you will be testing about the upper limb, lower limb, You can always see that there are certain things which is repeated, like here also upper limb recoil you will be checking, scarf sign you will be checking. Then again in lower limb there is the popliteal angle. All these things you will be checking in the muscles area, muscle tone. Then axial motor activity you will be checking, that tightening reaction you will be checking. Then how is the muscles, head, neck muscles, flexion muscles are there. So they have given the description also. So for example, if we take a tightening reaction, present, complete or not, excessive with arching or absent. So accordingly, you can give 0, 1, 2. And here, if you'll see about the neurological sign, what they are checking. So excitability they are seeing. Then they have also mentioned that certain things will be normalized in few days. So that also you can document. For example, the seizures. Uh, Maybe some seizures will get normalized in a few days. So they have written like normalized by 7 days, yes or no. So these all small documentation points are given very nicely. If you will read that paper and then you can learn about it. I'm not aware if there is any kind of training is given for this particular assessment or not. So when we talk about the Emil Tyson, definitely we remember that this angles, and we should be definitely aware of these angles where, when you jot down, that you will understand the child is having it as a normal range or not. Okay, so let's say from 0 to 3 months, the child adductor angle should be around 40 to 80 degrees. Popliteal angle should be around 80 to 100 degrees. Dorsiflexors angle should be around 60 to 70 degrees. Calf sign, the elbow does not cross the midline. Okay. So all those things, according to the age, they have given very nicely, and then you can have your small screening assessment, the about the muscle tone and the neurological signs and all. Then next come the general movement assessment. So to assess the neurological integrity of the infant central nervous system. So this is basically used for checking the integrity. So it is easy to perform. Like it takes only 3 to 5 minutes of video examination, and you should not be handling the child. It should be like there should not be any disturbance around the child cradle and all, and any person watching at the child and grabbing their attention, we should try to avoid all those things. The light should be good, it should not be too bright or too gloomy. So all those things should be taken care while you are taking the videos. Then documentation, it documents basically the trajectory of the movement development, how is the movement is developing in a child. Then it tells the wax and wane. Wax and wane is nothing, just the movement starts and the movement end. So how is the smoothness of the movement, varying in intensity. So is it very fast and then going down, or it's slowly in a particular rhythm it is. How is the speed they are seeing, then how is the range of motion, is it going very uh, like very far movement, or it's like slow and nearby the midline and all the child is moving. So those all things also you will be seeing. Then have and does it has a gradual onset and ending. So basically you're also seeing that around the joint, is it gradually coming or suddenly it is moved, the child is moving and all. So the score is from 5 to 28. The higher score indicate more optimal movement and the quality of movement. So basically you're more seeing about the quality of the movement, and its a sensitivity rate is very high. Specificity rate is also like 91%. So definitely when you are performing the general movement assessment, you will get very nice picture about the child's neural and the motor part. So there are certain things which I want to just focus. I'm not certified general movement assessment practitioner, but definitely I have read something and learned from my colleagues, so that I am just putting it here. So the infant's general movement are endogenously generated by the neural networks without intention and without a specific trigger. So that's why in this movement you're not, in this assessment you are not performing anything, you're not touching the child. It develops from the brain and that you're observing. They are typically present from 9 weeks postmenstrual age until 5 months of postterm age. Okay. Fetus and young infants develop a large repertoire of spontaneous movements such as stretching, yawning, twitching, and a specific motor pattern commonly known as general movement. So let's see here. Uh, this in this graph, if you will see, this is the green area on the top that tells about the almost 9 weeks to around 35 weeks or something like that, or 40 weeks. So that considered as a fetal movement. Then comes the breathing movement, where which develops around 40 weeks of gestation till around 2 weeks or 2 months or 6 weeks of the age. After that, till 5 months, from 2 months to the 5 months of age, the fidgety movement starts occurring. So you are basically observing this kind of movement. Are they present or not present? If present, are they, the quality of movement is good or not good? That so it has like normal or abnormal, or like if you'll see quality of concurrent movement pattern. So normal, abnormal, all these things you are jotting it down. And it doesn't take longer time also. It's like very fast. If this breathing movement or fidgety movement, if it is present, then you can say that the child movement pattern are good. So all those things are taught in the general movement assessment. So I think there is no online like they are not teaching online, but offline it is available. You can get trained into general movement assessment. So abnormal concurrent movement includes, for example, repetitive circular arm movement, excessive arching of trunk or neck, sudden burst of some activity, or asymmetrical segmental movement and absent leg movement. So basically, if we will see one video how this certain few movement are present in some of the babies. And adequate movement motor repertoire are kicking, hand to mouth, and leg lifting with or without knee bending, knee contact, and the visual explore, like child will observe at you and some do maybe focus or some tracking, something like that. Normal concurrent movement pattern are elegant and varied and involved rotational movement. For example, manipulation, like they're holding the clothes, or axial rotation, like nice the movement will be there, like a smooth movement. So if you will observe here, okay, so can you see that the child is suddenly like you can't hear the sound, but this video is available online as well. If you will search about the cramp synchrony movement, which is one of the abnormal general movement, and you will find that they have very nicely explained that what kind of movement you will be observing. Like basically, the child, if the child is suddenly moving hands and all, and then which is followed by the cry. that all things is something which is considered abnormal. So those things you will be observing. So this is definitely available online. If you'll search, you will understand what to observe. But yeah, the certification is a must. Without that, we will not be able to give the proper scoring and all. Then next comes the primary neuro examination. So it can be assessed in the preterm infant between 23 to 37 weeks of gestation, and also for the infant which is less than 1500 grams. So this is the only assessment which you can do when the child is still on the ventilator, and it's not state dependent, and it takes 1 to 5 minutes to do the assessment and record the start time. You need to just, because there are something which is dependent on the rate also, like how many times you saw the movement. So that's why you need to record the start time and the end time. Okay. Then score is based on a postmenstrual age at the time of evaluation, and it is a it will give the diagnostic category of abnormal, questionable, and normal. So let's see how it looks. So this is the primary neuro examination for preterm. If you will see here, it is divided into the three factors. So see in the right side of the screen, the factor one, which is neurological, factor two, which is movement, and the factor three is responsiveness, like what you did and something and you got some result like that. Then you will see here the gestation age. All it's written from 20. The left hand side it is given 23 weeks till 37 weeks it is given. Okay. So if you are seeing a child at let's say 34 weeks of gestation, you will draw a line from top to bottom, and then you will start performing whatever you have observed here. A, B, C, D, E, like that it is given. What you have observed, it has particular scoring for that. So let's say if I have observed here C, I will check at the this 34-week gestations line. There I will check in and I will find out, okay, C has the score of 3. So I will give the score of 3 for that particular performance. So like that, you will sum up all the scores. At the end, you will find the subtotal of like the normal is 100, and you can see the abnormal movement is the abnormal scores is less than 70. Questionable score is from 70 to 99, and normal is from more 100 or equal to 100. So this is, and that is when the child is more than 28 weeks of gestation and off respiration. If the child is in the respiratory support and child is less than 28 weeks, then the abnormal scoring is less than 50. Questionable is 50 to 69, and normal is around 70 to 80. So this score sheet is like easy to do. It takes lesser time also once you get good hands on this. Only thing is you need to find out the rates. For example, while you are doing the, let's say, arm recoil also, and if you have observed some leg movement, then you have to jot it down. So basically you have to remember that, okay, I saw certain things 4 or 5 times in whole assessment. So like that you will come to know that, okay, this many times the child has done. You will divide it from the time and then you will find it out the rate. Okay. So like that, there are facial grimaces, startle, all these things you need to like really understand that you have to observe other places also while you're performing one thing. Okay. And I'm again not sure that are they giving some kind of assessment certificate or not, like they are training or not. I'm not sure about that. But I learned it from somebody, so that's why I have kept it here. So this I have already explained to you. And let's move to the next slide. So like next comes the Hammersmith Infant Neurological Examination. So this I use very frequently. So you may see lots of information about the Hammersmith examination in my presentation. So you can do from the birth, like 40 weeks of corrected age till 2 months of age. Okay. And it evaluates the posture and tone pattern, reflexes, spontaneous movement, and abnormal neurological sign and orientation and the behavior. These are the aspects which you can see in the Hammersmith Infant Neurological Examination. This is the infant one. Okay. And it has a inter-tester reliability of 96%, and it is self-taught. It's available in the website of MacCath Press, that you can pay some 10 pound and something like that. You can take the subscription and you can learn about it. It's very easy also because they have given nice picture, and you just need to perform and check that where the child is falling. So it has 34 items, so which makes the score of 34. A score less than 28 is suboptimal, and 29 to 31 is borderline. Above the 32 and till 34, the child is having good score. So this is a paper, neurological examination of preterm infant at term equivalent age. So it explain about that how to perform this assessment. I'll just give you some small gist about it. So let's say we are taking the posture portion. Okay, so first thing, the extreme right and the extreme left in the picture of in these pictures are something which we don't want, are something which tells about the child is having either very high tone or very low tone. The middle three one are something which is acceptable. Okay. So, for example, if I am doing the assessment of a child who was born at 32 weeks of gestation, so you can see in the right side, sorry, the left side, the all the pictures, posture 1, 2, 3, 4, 5. Okay. Same here, you will see 1, 1.5, 2, 2.5, 3, 3.5, 4, 4.5, and 5. So these are the score you can give. Okay. If the child is falling in between, of course, you will be giving that 0.5 to the child. And if the child is falling particular to, let's say the child is having the posture of 2, so you can give them, you can mark it here at 2. But for my child who is 32 weeks of gestation, the expected posture for the child is the third one. So you can see the dark square here. That is the something which is very nice. You should expect that from the child. Okay. But if the child is falling somewhere uh, in the fourth score or the fifth score, then you can see the gray area. Okay, so the gray area, there is one black area and the gray area. So gray area is still acceptable. But if the child is falling other than that area, then that means that you will be giving the marks of 0. Otherwise, you can give marks of 1. Okay, so basically you will be seeing that child, the 32 weeks child, when the child is 40 week of gestation. You're not seeing at that time when the child is 32 weeks. Okay. So, but you are observing the scores of the 32. Here it's written 32 to 34 weeks. So in this paper, they have explained how to score this particular preterm at their term equivalent age. Okay. So then you will be giving the score of 0 and 1, and then you will sum it up, and then you can tell that how where the child is falling, how is the child improvement are there or not. You can even do it after that also, because you will be doing at 40 weeks, then you can do after 1 month, and again 1 month, so you can understand the child is performing well or not. Then comes the infant Hammersmith infant neurological examination, and it is very much recommended, uh, and it's used for early diagnosis of cerebral palsy. And the HINE is simple, scoreable, standardized clinical neurological examination for infant between 2 to 24 months. Over 5 months of, you can also do the corrected age over 5 months, and it has 90% of predictive accuracy for detecting the risk of cerebral palsy. And it has three part. There is one neurological examination which is scoreable, then developmental milestone which is non-scoreable, and behavior also which is non-scoreable. Okay. So the score goes this, it has 5 domains and 26 items basically. And the score goes from 0, 1, 2, and 3. So remember, the previously you were giving 0.5. Here you are not giving 0.5. Okay. The maximum score for any one item is a 3. Okay. And the minimum score is 0. So the total score maximum the child can gain is 78, which is the which you can say the performance is very good. So the exam sheet looks like something like this, where they have already given and written all the explanation, what you should be observing and where you should be doing the markings, and some basic information you will be filling it up. And then you can write your comments also in the first page, that you want to send the child for intervention or not. Let's see how to decide, okay, that you want to send for intervention or not. So what happens, there is something called optimal score cutoff. So let's say the child who is smaller will definitely get some less markings. So from 3 months or less than that, the child will score, if the child scores 67, that is okay. 6 months baby, if they score 70, that is also okay. 9 to 12 months, if the child is scoring around 73, then also it's okay. So these are some cutoff. Okay. Then what are the global scores? So if the child is scoring less than 56 at 3 months, then you will be sending them for the some kind of observation or intervention, something like that. If the child is scoring less than 59 at 6 months, less than 62 at 9 months, and less than 65 at 12 months, then definitely this child needs some kind of attentions. Uh, okay, this I have already told. Okay, so the Heinz score at 3, 6, 9, and 12 months, it is very nicely has the correlation with the GMFCS. So 50 to 73 indicates a likely unilateral CP. Okay, so 90 to, it says that 90 to 90, 95 to 99% the child will walk. If the score is less than 50, then it indicates bilateral CP. Uh, if the Heinz score at 3 to 6 months is between 40 to 60, it indicates likely the child will fall under the GMFCS level 1 or 2. If the score is less than 40, it indicates the child will fall under the level GMFCS level 3 to 4. So higher score, lower GMFCS level. Okay. So then you will correlate it, and then you can tell that, okay, these childs are having the higher score, but level should be the, the GMFCS level is low. Okay. And then you can send them for some interventions. So global score below 40 on the hind was always associated with severe motor impairment at the 2 years of age. So basically, what we say, the child, those who can sit between from 0 to 2 years of age, the chances of walking is more. So all those things, the correlation is came from this hind scoring and the GMFCS level. So that it's very nice to learn about this hind and GMFCS, what they explain. And GMFCS also has revised version now. You can read about that. So score greater than 60, the these things you can remember, the score greater than 60 is always associated with the normal outcome. Okay. So let's move to the something which is very different, newborn behavior observation scale. So it is designed to help the parent and the practitioner to understand the newborn's language. So as the name says, the behavior you will be observing, it's more about the observation. Okay, and then you have to observe the baby's behavior, basically their patterns, and then you will be finding about the strength of the baby and where the child needs support, like that. So basically it is more for helping the mothers that okay, you see that your child is performing this much, your child can do that much, so that will give some boost up to the mother. Okay, my child is doing good. And then where else the child needs support, that you just inform the mother. It can be used from birth till 3 years of age, sorry, 3 months of age, and it has 18 items. So it includes the self-regulation, response to stress, visual and auditory and social interaction capacity, and the habituation from light and sound, and motor pattern and the activity level. So the proforma looks something like this. Something like this, it will look. All the things are written here, and then the marking will be from 1 to 3, where the where you can tell that the child is doing very good, means the child will get the 3 marks definitely, and if a child is not able to do that particular thing, then child will get the 1 marks. Okay. So the NBO has a very nice this book which comes with their training package, and then you can read more detailed about the child behavior, how the child develops in, and how initial age, what all behavior you can observe, which is quite normal, and which is needed basically. If it is not there, then that's a red flag. So those things are very nicely explained in this book, understanding the newborn behavior and early relationship. It is also available separately, but if you are going for that, then training online and offline both is available through Brazelton Center UK, and you can go for the training. It's like 2 days training, and then you can like do this. It doesn't take much time also. You can do while the child is going to get discharge, and then in the follow-up also you can do. Or if then any health care worker is going to their home and doing some assessment and helping the mother, that way also you can use this assessment. So this is the end part of our lecture. I should have kept this earlier, but let's understand what is called the state. So it's important to consider throughout the test is the state of consciousness or the state of the infant. So a state is achieved if the child is in particular state for at least 15 minutes, sorry, 15 seconds. Then you can say, okay, this is the state of the child. State depends on physiological variables such as hunger, nutrition, degree of hydration, and the sleep and awake cycle of the infant. So we know very well if, for example, if we are hungry, definitely we may show some kind of signs. We can talk, so it's okay. Child will show signs by crying or putting the hands near the mouth or looking for the milk rooting and all. You can see if the child is not medically stable, then the child will be more dull. So it's very much dependent about the physiological variables. Then this is the best predictor of child receptive and ability to respond to the stimuli in a cognitive sense. So basically, whatever the child is absorbing, how the child is processing and reflecting back. So this is what the state of the child tells. And the state in the state one, the growth hormone is active. So that's why the state one, which is called the sleep. I'm very sorry for this busy slide, but it's very important to put everything here because it talks very detailed about the, let's say, the quiet sleep. Sleep with regular breathing, eyes closed, no spontaneous activity. So, like that, they have given no jerky movement. You can see nothing. The child is having rapid eye movement and all. So, it has written very nicely that when to consider child in what state. And whenever we are performing any kind of assessment, definitely you want your child to be in the quiet awake or active awake state. If we are performing in a crying or drowsy, sleeping, of course, is not possible. But then, if you are performing at that time, you are not getting your correct result of the assessment. So here you can see there are some pictures just to give you just how it looks like. The baby is hard to wake. If you'll see the quiet sleep and then active sleep, if you see the baby moves the hand, face, and the eyes. Little movement you will see. In drowsy, the child will little bit open the eyes and then probably see and then again sleep. If the child is quite alert, the child will open the eyes and look here and there. Active alert, the child the wide little wide open and then some more movement will be observed. Maybe sometime try to go just about to go in a fuzziness and all. And of course the crying we all know. So these are the six state which we should be aware of. And now this is the last tool which I'm going to explain. This is also very gold standardized assessment which is used in the NICU, which is called NOMAS. You can get the certification online and offline both. So what it tells about the neonatal sucking pattern and suck, swallow, breathe rhythm in preterm and term infant. It identifies normal pattern and to differentiate disorganized or dysfunctional pattern in a poor feeder. Okay, so it has 28 items to assess the tongue and the jaw movement. So basically, you are observing the child and how is the child tongue and the jaw movement. It is few items only I have kept here. So, for example, if you see the first constant degree of jaw depression, that is called normal. If you will see the disorganization, so inconsistent degree of jaw depression, which is again little different, is dysfunctional. Excessive wide excursion that interrupts the intraoral seal on the nipple. So disorganized is basically nothing but something which is like they are trying to perform but not able to perform in a proper manner. Dysfunctional is something more related to neurological, which the function is not present basically. So like that, in a easy word you can understand. So there are some difference between disorganization and dysfunctional. So if the child has a dysfunctional issues, then definitely the child need a very like immediate intervention. And you need to look into that, if the tongue is flaccid, not cupping well and all. So that also, if the groove is not formed, and sometime it is forming, sometime it is not forming, then it comes under the disorganization. So basically you can train that kind of babies. So the other babies, it will take little longer time. So then you can decide that you want to go for the intervention immediately right now and then continue it for a longer time, or you want to do the intervention few days and then that this child will improve. So like that, your clinical decision will vary, and then you can also speak with the parents that how frequently the intervention should go, or your child will need a little longer time to recover. So this is a very nice tool that you can read about, which is called NOMAS. And with that, I will finish my lecture here, and thank you so much for joining. If you have any doubt or any question, you can reach me. Plus, one more thing, that there are more assessment than this, which people are using in their setting. It's purely depend upon your setting, and how much you're easily able to do the assessment and come up with some kind of intervention. So don't go for all the assessment, but at least there should be some assessment which we should be doing in the NICU and later on for the follow up, so that you will not miss any child, and at particular proper time you will send the child for the early intervention, because it's very important for their growth and development. So these are some reference, and thank you so much for joining.